test you on it. But if I'm talking to you slow, I'm going to test you on it, okay? Oh, all right, so block 4, we're going to be talking about immunohematology. We have 5 lectures. I'm going to do blood bank 1 and 2, and then I'm going to go over body fluids. Of course, Colonel Johnson will do toxicology, and then on Monday, I will do the reliability. And we should be good. By the 17th, y'all should be good, okay? So I know we have a lot of experts in the rooms. I know we have people that have already done blood transfusions, and you kind of know this stuff, right? So I don't have to, like, be slow. Maybe I can skip your stuff, okay? But if I'm going too fast, please let me know. Well, I think my clicker's fine because it was working in my office. I think it's not working up here. So I don't know if I'm on the wrong screen. What? Okay, y'all can chill for a couple minutes so I can get my shit together. I thought I did, but I don't. All right. All right, there we go. All right, so TLOs, action conditions and standards, always the same. ELOs, we're going to be going over ABO blood typing. We're going to go over the RH system, how this impacts childbearing. We're going to discuss direct and indirect testing and their purposes, and typing and screening and typing and cross-testing. All right. So this comes from our lovely reference, chapter 36, and here is our clinical introduction scenario. A 27-year-old female presents to the ED following a motor vehicle accident with significant blood loss. Due to urgency, uncross-matched O-negative packed red blood cells are administered. Once stabilized, a type and screen reveals that she is A-negative with a positive antibody screen. Further testing identifies anti-KEL antibodies, requiring selection of antigen-negative compatible donor units for safe transfusion. Okay. You already saw the video yesterday. All right, this is our agenda. Okay, so what is immunohematology? So immunohematology just focuses on those red blood cell antigens and antibodies. So I know that you all have already had that pathology block, so I'm not going to go too much into the basics. We're going to just review it very, very quickly, but we're just going to pretty much take what you learned in pathology and we're just going to add what laboratory tests do we use to determine these antigens and antibodies, okay? So this is a good important slide. I will ask you this on the test, all right? So in our terminology, just know that a donor is the one that provides the blood, while the recipient is the one that's receiving the blood. All right? So the goal of immunohematology, blood transfusions. That's why we do it. That's why there's always asking for donations, because it's always needed and we're always low. All right, so the goal here is restore or maintain oxygen carrying capacity. That's within your hemoglobin. This is to restore and maintain blood volume for those that have had trauma or had a hypovolemic shock. It replaces coagulation factors, so those that have liver disease or major surgery. And then it restores or maintains leukocyte function, so those that have neutropenia from either chemotherapy or bone marrow disorders. All right, so we know the blood types. What are the blood types? Y'all know them. A, B, and O, right? All right, our dominants are A and B, and that recessive is the O. So then we're going to go through some Punnett squares. I think y'all got this down, right? Y'all seen this before. Y'all seen all of this before, so click, 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 click. Okay. Click. All right, so the Bombay phenotype. Now, I hate testing y'all stuff on rare things, but for whatever reason, the Bombay phenotype is on the test, so just make sure you highlight that and know it. All right, in my 24 years in the military, I've never seen this, but they just love testing this on the Bombay phenotype, all right? So the Bombay phenotype lacks the A, B, and H antigens on red blood cells, and the plasma contains anti-A, anti-B, and anti-H. The reason why it's important is because it does resemble that type O blood, but it's incompatible with type O blood, okay? So that's really pretty much all you all need to know. As far as laboratorians, we do a lot of additional testing to distinguish a Bombay phenotype from a true O type blood, okay? All right, so here's the frequency of ABO antigens. So type O is the most common, right? And type O is the universal what? Universal donor. Who's the universal recipient? Yeah. All right, so this is another slide I'm probably going to test y'all on. All right, so antibodies are formed. ABO antibodies are naturally occurring and develop in response to environmental antigens that resembles A or B antigens. So this next one here, this natural sensitization, I probably will come up with a question on that. So by 6 months of age, humans will develop antibodies against A or B antigens not present on their own red blood cells. All right, and that clinical scenario looks really good. All right, so the ABO system. So you know that the blood type O has no antigens on the red blood cells, but they have the A, B antibodies in their serum, right? A has the A antigen with an anti-B in the plasma serum. B has the B antigens on RBCs with the antibody A in the serum. AB has A and B on the red blood cells, none in the plasma serum, and then that Bombay has none, but it has all those antigens, so antibodies, so H, A, and B in the plasma serum, and it has that HH phenotype, okay? I think y'all know this slide, but just highlight it, okay? All right, so the RH system. The RH system is what determines whether you have positive or negative blood. So antigens of the RH system include big D, big C, big E, little c, and little e. Okay? Individuals with the D antigen are positive. That's about 80 to 85% of the population, while those that lack that D antigen are Rh negative, and that's about 15 to 20% of the population, general population in the U.S. Okay? Anti-D antibody formation in those Rh negative individuals will produce that anti-D antibody when exposed to Rh positive blood. And so this can happen through pregnancy or transfusion, right? So if a mother is Rh negative, she's carrying a Rh positive baby, she's going to probably start attacking that fetus, right? And so she needs that shot of Rovium to synthesize everything so she doesn't kill that baby, right? Okay, so you'll be tested on something like that, and we'll see a little later. I have a slide that I want y'all to look at. So if it's FYI, it's just nice to know. Now in lab school, we actually spend like 6 weeks on this, but y'all gonna get it in like 40 minutes, so you'll be good. But yes, we go through each one of these blood groups. You have to know all this stuff. It's very, very, very meticulous. 47 blood groups, and there's 362 RBC antigens. but that's just FYI for you all. So for this lecture, this is what we're going over: ABO and RH typing, antibody screening, antibody identification, cross-matching, and then anti-human globulin AHG test. All right. So the basic principles when dealing with blood banking tests and procedures is hemagglutination. So this is vital. This is our endpoint for detecting RBC antigens and antibodies in most of our tests. So it comes in hemagglutination is in 2 stages. You have your first stage, which is your synthesization. This is that initial bonding of antigen and antibodies through those non-covalent interactions. And then you have your stage 2, which is your lattice formation, which is those visible agglutination. And even though I don't know why we haven't talked about it yet, but when you do submit the samples, it will be submitted in this EDTA tube, which will be lavender top or blue top tube. And we'll have another, I think it's lecture 5, we'll talk more about the types of tubes, okay? So ABO and RH typing, please highlight this because you will be tested on forward typing and reverse typing, okay? So ABO typing, A, B, or O, RH, positive or negative. When we determine this in the lab, we start off by forward typing is the test. And you can see down the bottom. Forward typing is where we mix the patient's cell with our commercially created antibodies. These are our reagents. These antibodies are actually non-human. They usually come from either rats or rabbits. And so what we do is we'll take the patient's cells, we'll mix it with the antibodies, and depending on the result will help us determine what their blood type is, okay? So forward typing is ABO antigens on the patient's RBCs mixed with those antibodies. All right? So an O would be mixed with antibody A and anti-B. It's negative. So you already know that person's O. If their RH typing comes back positive, you know that they're positive, so you know that person's O positive, right? So then in reverse typing, what you're taking is either plasma or serum, and you're adding that to commercially created red cells. And so these red cells do come from people, but they've been manipulated and manufactured so that it's in like an FDA reagent. And so what we'll do is we'll take that person's serum, we'll add those red cells to it. So we will add an A cell, and we'll add a B cell. These are going to be in 2 different tubes. So if both are positive, that will confirm that that person's an O, and you know that this is O positive. So that's pretty much what this chart is saying. So on your test, I will provide you with a forward type result, and then I would want for you to tell me what the reverse typing will look like, okay? So if you got that, it's about 2 questions that I'll ask you. And if you know this chart, you'll be good to go. All right, so I'm gonna go through these quickly. Antibody screening. Besides ABO and RH, everything else will be done in the lab, so this is not anything you all will see. All right, so antibody screening pretty much is where we're detecting antibodies. We're going to do, it's not really quick. It takes a minute if it's done manually. And pretty much what we're doing is we're taking the patient's plasma, and then we're adding what's called indirect antiglobulin tests to it. And pretty much what we're doing is we're illuminating those antibodies in that blood if it's there. And so we do a series of tests where we're adding drops and spinning it down. We're looking into the tube to see if there's agglutination, and we do this several times. We do this about 3 times. We're washing cells, spinning them down, heating them up, looking at them, okay? And so here I think it's about, 1, 2, 3, 4. There's about 7, but sometimes you can go up to about 20 times that we're doing this. So it can be very, very meticulous. So during the antibody screen, we're just identifying antibodies, okay? Now the antibody identification, so an antibody we found an antibody, now we need to know what specific antibody it is. And so we'll have a series of red cells that are all implanted with these different antibodies. We add them to the plasma and go over and do the same thing. We'll put drops in each tube. We'll add the antiglobulin to it, right? We'll spin it down, we'll look at it, and we'll keep washing it until about 5 or 6 times, and then we'll annotate it on this card. So luckily for y'all ain't got none of that, okay? So cross-matching. Cross-matching, this is important because you will be tested on cross-matching, okay? Cross-matching is pretty much where we're confirming the blood's compatibility before transfusing it into the patient. So what we're doing is we're mixing the recipient, so the person that's going to be receiving this blood, we're mixing it with the donor's red blood cells. So please make sure you understand it, okay? So cross-matching is mixing the patient's serum with the donor's red blood cells, okay? And with cross-matching, we have two different types. We have a major cross-match and we have a minor cross-match. So major cross-match, you're looking at the antibodies in the recipient's plasma against the donor's red blood cells, okay? That's a major cross-match. In a minor cross-match, we're looking for antibodies in the donor, so the one giving the blood, against the recipient's red blood cells, okay? So highlight those two. We'll see that again. And so what defines incompatibility? Agglutination, all right? So in a major incompatibility, that means that the recipient's antibodies are attacking the donor's antigens. That's major. A minor incompatibility is when the donor's antibodies are attacking the recipient's antigens, okay? So if you got that concept, you're good, all right? There. All right, so just as I said, there was a major cross-match and a minor cross-match. Now there's two different types of major cross-match. So we have one that we use in emergency situations, and then we have one that we use during normal situations like pre-op, all right? So your emergency major cross-match test would be the immediate spin cross-match, okay? And all we're doing is we're mixing the patient's plasma or serum with the donor cell. We're doing an immediate centrifugation, 15 seconds. We're checking to see if it's agglutination. If not, good to go, right? And we'll issue the blood real quick. So that's really only a time when you see trauma, things coming into ED. Now, if you already have someone, oh, and also this is with somebody that has no history of blood transfusions and has no known antibodies. We will do an immediate spin cross-match and get you that blood as fast as possible. All right? Now, another form of a major cross-match will be that AHG. This involves, it says 3 steps, but it's way more than 3 steps, just for the sake of testing it's 2 steps, okay? This is for patients with known antibodies or a history of transfusions, and this is used in non-emergency situations. Okay, so 2 major cross-match, what are the cross-matches now? We have major and we have minor. And then the 2 types of major cross-matches are immediate spin, AHG. Okay, good. That's all you need though. So this is FYI, this is what it looks like. If we were in the lab, I would actually show you what it looks like, but we're not. So we're going to skip it. All right, so emergency release of uncross-matched blood. All right, so usually in any medical center, especially in the ED, you're always going to have a small refrigerator that's going to have at least 2 Group O negative packed RBCs available in case you do have a trauma that comes in. You can't get the labs, you can't get samples to us in the lab quick enough, and you need those 2. You as the clinician can grab those, sign a release form, and put those into your patient, okay? There will always be Group O negative packed RBCs. Those are the 2, that's the units that you need in an emergency situation, okay? But if not an emergency situation, you're getting somebody prepared for surgery, you do want to ensure that proper collection is done. So you want accurate blood specimen collection. You want to make sure your paperwork is correct. You want to make sure that the specimen is valid. A lot of times, pre-transfusion specimens, and what I mean by that is all those labs that you collect prior to transfusing a patient are usually only good about 72 hours. Okay, so if you know the surgery is going to be a little longer than that, please postpone or wait till you get a little closer to that surgery to provide us those labs. And then make sure that you have the correct identification of the donor unit and the recipient, because those are very common errors, labeling errors that we see. Not too often, but it does happen. All right, so we have the anti-human globulin test. It's that AHG reagent, okay? And then here it just says the DAT is in vivo versus the IAT is in vitro. I'm not testing you on that. All right, but like I had said before, the AHG is that manufactured antibody that we get from rabbits. As you can see, that poor little rabbit's being injected by some human sera. It creates those antibodies. We take that out of the rabbit. make a reagent out of it, and that is what we use in blood bank. Okay, so this says DAT versus IAT. That was already on a previous slide. So DAT, just think in the body, we're testing things that are going on within the body, versus that IAT, we're testing outside the body. This is all done prior to transfusing. Okay, so this slide, yes, is important. And the reason why it's important, because I want you all to know that direct antiglobulin testing, that DAT, is used to diagnose autoimmune hemolytic anemia. There is a question that will ask you that. Okay? And IAT, when we're doing indirect antiglobulin testing, when we're testing the patient's plasma in vitro, we use type and screen and type and cross. And we'll talk a little bit more about that here on this slide that just came up. All right, so type and screen. Type and screen is a pre-transfusion order. Okay, it's used when transfusions might not be needed, but it is certain, and sometimes it's used in elective surgeries or pre-op assessments. So this will determine your ABO-RH and screens for unexpected antibodies. Okay, your type and cross. These are for your more urgent transfusions. This is used in emergencies or for high transfusion probability. A type and cross will confirm an ABO-RH, screen for antibodies, and do a cross match with the donor blood. Okay, so you will see this again on the test. All right, requesting for blood products. So ideally, the best blood product would be the one that matches your patient's blood, right? So if you have someone that has blood type A, you want to have A blood, but sometimes that's not possible, right? So you got to know the difference between those major incompatibilities and those minor incompatibilities, all right? And I know it was stated earlier in some other slides, but got to reiterate it again, all right? So major incompatibility, a recipient ABO antibodies are incompatible with the donor's ABO antigens. And then a minor incompatibility is where the donor ABO antibodies are incompatible with the recipient's antigens. Okay. All right, so RH compatibility. So RH positive patients can receive positive or negative. They're good. But negative, RH negative patients can only receive blood from other RH negative people, all right? So please don't give RH negative folks RH positive units. That'll be a no-go. All right, so we already know, that universal donor is that O blood, the universal donor of PRBC is that O negative blood, and we already know that AB blood types is the universal recipient. All right, so when selecting plasma for transfusions, we use what's called fresh frozen plasma, or FFP. All right, so this is derived from that liquid portion of the blood, and it's stored frozen for later use. The FFP should be ABO compatible for transfusions, and with FFP, RH is not a factor. So whether it's positive or negative, you can still transfuse it until transfusion. All right, so this is an important slide. I will create a couple of questions off of this. So if you have a patient with blood type A, what blood products can they receive based off of this slide? They can receive A blood. And what kind of FFP can they receive? A and AB. Okay, so I'm gonna ask you something like that. You got a patient that came into the ER. They're bleeding out from a gunshot wound. You need to order 2 packs of blood. Your patient's a B. What do you order? You order a B or an O for PRBCs, and you can order a B or AB for everything. So something along those lines, okay? All right, so platelets. So anytime that I've ever participated in any type of mass cow, leadership loves to order platelets. But platelets are very, not that they're difficult to get, it's just that they don't last long. Once we get platelets come out the body, they're only good at room temperature for about a week. And so just be cognizant of that. If you ever participate in any type of exercise, and you're like, we need blood products, we need platelets, it's kind of hard to get platelets. They're high demand, they love them, but you're better off ordering your packed RBCs or low O titer blood. We're gonna have that more in abundance than plasma or platelets, okay? So platelets are AB incompatible. We talked about platelet refractories in one, so I'm not gonna go over that again. But it may be needed for those females of childbearing age, and supply can be limited. Oh, look at that. And now we hit ELOs, okay, and the questions, and then we're gonna move on to the second one. I forgot how fast I went through that. No, I wasn't expecting on that fast. All right, so let's go to number 2. Really, this could have been all one lecture, but it's okay. Y'all not fighting for your life like I am right now? I am dying up here. Woo! Okay. Did you show up? All right, so blood bank 2, we're just going to continue on what we're talking about. All right, same chapter. All right, clinical introduction scenario. A 64-year-old patient with a history of myelodysplastic syndrome presents with symptomatic anemia. He requires a transfusion but has no prior febrile non-hemolytic reactions. The team orders a leukocyte-reduced packed red blood cells. Post-transfusion, he develops rigors and hypotension. The transfusion is stopped, and transfusion protocols, clerical checks, are reviewed for safety gaps. Cultures from the blood product confirm bacterial contamination, and antibiotics are initiated based on local antibiogram and susceptibility report. I hate that word, never get it right. All right, so just as we did in our little 5-minute video, we know that blood saves lives. So if you can donate blood, please do. Please, please do. And everybody understands the difference between row 1, row 2, row 3, for the most part? Yeah? Yeah. I know y'all in the back, but y'all in the front. Y'all know? Okay, yeah, so row ones will be like your aid stations, right? You all will be that senior clinician. You'll have your team of medics, you'll have your team of medics there, and you're there at the site of injury. Then you have your row 2s, which is more like your clinics, right? Row 2s, you'll have a limited lab, limited radiology, limited mental health, what else you have for row 2? Dental, yeah, right? And usually that's just a clinic. No, they don't do any inpatient, right? Row 3, then you're getting more into a field hospital or combat support hospital. I don't know the equivalents in the other services, Air Force, Marines, Navy, I'm sorry, I don't know. But you have a little more capability there. You can actually have inpatients. I think the minimum is 180 beds in a row 3. And then row 4s will be your trauma center, so your BAMSs, your Walter Reeds, and things like that, okay? So when they say whole blood transfusion is focused at row 2 and row 3, so think those clinics and those field hospitals, all right? And 90% of combat deaths occur before reaching that row 2. But at the end of the day, blood saves lives, okay? That's all we need to know there. All right, so here are available blood components. So usually at any major medical center, this is the inventory that we're going to have in transfusion services, specifically blood bank. All right, so we'll have whole blood, and so what encompasses whole blood is your fresh whole blood, and that is a walking blood bank. Does everyone know what a walking blood bank is? Heard of that concept before? I see some yeses. All right, so those walking blood banks, pretty much I'm a walking blood bank, right? If I can donate blood, there's a mass count going on, and you know I'm O negative, and somebody needs my blood, you can go ahead and stick me, get my blood, and put it to that patient. Okay, so that's what blocking blood bank means. That's usually, you all as PAs may have an inventory, but a lot of times us as laboratorians will keep that list available for you all, because we'll run those pre-transfusion testing and things like that for you all before you issue those blood out. All right, then you have stored whole blood, and then you have low titer group O whole blood. All right, so then you have red blood cells that are liquid. You have red blood cells that are frozen. You don't usually see that here in the United States. I know Korea had a very big inventory at the blood support detachment on Camp Humphreys, so not so much here in the States. And then plasma, which consists of that fresh frozen plasma. Then we have cryoprecipitate that comes off of the FFP, and then we have apheresis platelets. So we have room temperature and cold storage platelets. All right, so these are our tactical combat casualty care guidelines. I won't test you on this, but you probably will see this if you are the senior PA in your unit. You will need to know this later on. So this is FYI for later on, but not to be tested here in this class. All right, so blood products for transfusion. So we have our whole blood. Our whole blood contains red blood cells, white blood cells, platelets, and plasma. All right, so it's about 400 to 550 milliliters per bag, and it's good for about 35 days. You'll see this a lot in deployed environments. Then you have your low titer O whole blood. This is whole blood without the low anti-A and anti-B to reduce that hemolysis risk. Same, about 400 to 550 milliliters, and it's good for about 21 days. And this is good for those emergency transfusions, and all blood groups can take this blood, low O whole blood. And then we have packed RBCs. Remember I say there'll be about 2 left in the ED for you. If you do have an emergency that comes in, you can't get to the lab quickly, you can utilize those for your patients that come in. So they're usually, those red blood cells are coated with what's called CPDA or AS. This is just keeps them, it preserves them so that they can last a little longer. So if it's coated with CPDA, they're good for about 35 days. If it's coated with AS, it's good for 42 days. And used for anemia, trauma, surgery, or some other medical conditions. Don't worry about that. All right. Changes in cell-based blood products during storage. So things that can happen while it's sitting in a refrigerator, pretty much. So glucose can decrease over time, DPG can decrease, and the ATP can decrease over time with these blood products, okay? The big one is the increasing when sitting in the refrigerator, right? So hemolysis can occur because there's still the blood has still been processed, so damages can occur to those cells. The potassium levels actually increase a lot, so this does have a risk of creating hyperkalemia in recipients, and then the sodium content also increases due to that anticoagulant that's coating those red blood cells. So these are components that require special preparation. So we'll talk about leukocyte-reduced packed RBCs, washed PRBCs, irradiated PRBCs, and then CMV negative PRBCs. All right. So leukocyte-reduced PRBCs. So pretty much the white blood cells have been wiped out. Okay, we've removed them, took them all out through a series of tests and filters and centrifugation. And once you have a leukocyte-reduced PRBC, this unit is good for 42 days. This is good for those that leukocyte-reduced is used mostly for those that are going through G6PD and stem cell transplants. We tend to give leukocyte-reduced PRBCs to these patients. This also helps prevent that graft versus host disease if they do receive implants. Okay, washed PRBCs, I will test you on washed PRBCs, okay? So washed PRBCs is when that plasma is removed, and this is through multiple washings with normal saline, and we reduce the amount of plasma proteins in this product, okay? So once a PRBC is now washed, it is only good for 24 hours, right? And the reason why I'm going to test you on this is because you need to know that if you have a patient with autoimmune hemolytic anemia, the preferred unit for them is a washed PRBC unit, okay? Make sure you get that down. All right, irradiated, I will test you on this as well. So irradiated PRBC units, like I said, those are those that are immunocompromised, and those that have that T cell proliferation. This prevents that. Irradiated PRBCs helps prevent the transfusion-associated graft versus host disease. Okay? And in irradiated PRBCs, we're removing whole blood, we're removing granulocytes and platelets. And then here's another one I will test you on, so CMV negative PRBCs. So these are best for immunocompromised patients and pregnant women. Okay. So do you remember what virus CMV is? Cytomegalovirus, and it's a type of herpes, right? And so about 1 in 4 Americans have herpes, either herpes 1 or 2. So we actually get a lot of units that does have CMV in it. So it's only about 15% units that we receive that are CMV negative. All right, so let's move on to plasma-based products. All right, plasma, fresh frozen plasma. So plasma is separated from the cells, and then they're frozen with 8 hours of FFP or within 24 hours of PF24. The plasma is kept at negative 18 degrees Celsius or colder and can be kept for up to a year. But once it's thawed at 37 degrees Celsius, it's only good for 24 hours. Okay. Cryo, so this is important. Make sure you're starring this slide as well. Cryo is an anti-hemolytic factor, and it is derived from the FFP. All right. It's thawed at 1 to 6 degrees Celsius and then centrifuged to concentrate those clotting proteins. So if you have a patient with that hypofibrinogenemia, the preferred blood component unit to use for them is cryoprecipitate. Okay, you will see that again. Ooh, it's hot. Platelets. Platelets, all right, separated from whole blood via centrifuge and obtain platelet-rich plasma, okay? Like I said, clinicians love platelets, but sometimes we can't get them to. We try though, we try. So they're stored at room temperature. They're good for 5 to 7 days. They're stored at room temperature, and they have to be continuously agitated so that they don't start clotting on each other. And then you have cold storage, which you place in the refrigerator, and those are good for 14 days. So very short shelf life, and they're always in and out, constantly in the blood bank. All right. So plasma derivatives. We already talked a lot about factors in our first lecture. So you know I'm gonna run through these. You already know. All right. So plasma derivatives. Remember we talked about hemophilia A and the factors that were associated with that. We talked about hemophilia B and the factors that are associated with that. So just know that plasma derivatives prevents that hemolytic disease of the newborn. I already tested y'all on that. But I will test you on this, okay? So RhoGAM, that Rho-D immune globulin, this prevents Rh incompatibility for Rh negative women who are pregnant with an Rh positive fetus. All right, so at about between 28 to 30 weeks of pregnancy, if an Rh negative woman has an Rh positive baby, she will receive that RhoGAM shot, and it is applied antepartum. Okay, and then once she has the baby, she will then get another shot within 72 hours after having the child, and that will keep her, if she does have future pregnancies, that will keep her from it has another positive baby, that Rh enemy formation that could affect future pregnancies. Okay. If there's a risk of fetal maternal hemorrhage, RhoGAM can be given before the 28th week. Okay. And then also this area here that's highlighted that says it's assessed via Howard-Beck test, or AKA acid elution test. You'll see that on the test as well. You'll see that on the exam. I don't know if it's on your slides, but just make sure you write it. Okay. So pretty much this is just saying if the mother's positive, you don't have to worry about precautions. If the mother's negative, she's carrying a positive baby, the precautions you take is to give her that RhoGAM shot at 28 weeks. And then within 72 hours after having that baby. Okay, so detection of fetal hemoglobin. So that's that test again, that acid elution test. It just talks about the purpose, the significance, the method. This is nice and all, but I already told you about some testing myself. You want to highlight it's good. And this is just what it looks like under the microscope. So if you detect that you have one of your pregnant patients has a fetal hemorrhage going on, this is what we'll see under the microscope. So the RBCs, her RBCs will look ghost-like. They'll be kind of very light and shadowy, and then you can see the baby's RBCs will be really dark and small. This is just FYI. This is some stuff that I know is still, I don't know, all you all in the back, if y'all use this stuff, because I know y'all get stuff before we do. Huh? You have? Yeah, what'd y'all think of it? It takes up a lot. It does. Why is it? Really? Yeah. Yeah, that's not convenient, is it? No. Not if you're out, like, yeah. Okay. Have you used it in real time and actually, like, transfused?
Not on a patient. I had a whole unit get accidentally consumed.
I want to know.
I told my captains, hey, time out.
Yeah.
You pointed at me like that.
Really? Was he a PA?
No.
He was not? Oh, okay. Don't do that, y'all. Please listen to your minutes, okay? Okay. Well, yeah, so this is in development, meaning we don't have this in a hospital. We don't have this in labs, but I know a lot of you all have used a lot of these.
It's still not.
Yeah, it's what?
It's still not.
I don't think so. Not that I'm aware of. I would have to ask one of my, I'm not a blood banker, you know, Major Guzman was a blood banker, so he was all up on
We
this
had to
stuff.
sign like a waiver.
Did y'all to even use it? Yeah, that's what I figured. But I know that none of this right now is used on like our patient population at all. But they don't mind experimenting on us, right? No problem with that. Okay, cool. All right, and this is just some more still in development. Okay, we are not using that in our hospitals. We're not using it in TOT at all. Okay. All right, so if you suspect that your patient is having a reaction, stop the transfusion. Doesn't matter, just stop. Cut it off, pull it out of their arm, okay? If you have the time, please collect another sample off that patient, send it to us. We will run some additional testing to see what is going on with your patient, okay? So I will test you on certain types of transfusion reactions, okay? So you have immune transfusion reactions, right? This is when that blood group incompatibility or alloimmunization or HDN. And the reactions you'll see may be febrile, a lethal will be acute hemolytic reactions, a classic may be a delayed hemolytic reaction. And these are relatively less common. So I'm not going to test you on that. But I will test you on non-immune transfusion reactions, all right? This is caused by factors other than the recipient's immune response. So a lot of times in those non-immune transfusion reactions, it's usually just overload. They received too much product or they got it too fast, and then the body just kind of reacts negatively. A lot of times too, if there's some type of bacterial infection from those units that may occur, and then if that patient has metabolic disorders, okay? So non-immune transfusion reaction. All right, so then you have febrile reactions, acute hemolytic reactions, and delayed hemolytic reactions. All right, but you will see these. So febrile non-hemolytic reactions, that's caused by those cytokines that accumulate in the blood. In the labs, we will not see hemolysis, but we will do blood cultures and to rule out other infections. All right. Then you have your most lethal, which is your trolley, transfusion-associated acute lung injuries. This is activated by the recipient's neutrophils by the donor-derived antibodies. All right. So what we'll do if you your patient has a trolley, the labs you'll see will be pulmonary leukostasis, endothelial damage. We'll look for that. capillary leak. Will ID a pulmonary edema within 6 hours of transfusion. And then some other tests would be x-rays and pulmonary function tests. And then lastly, for the TACO, transfusion-associated circulatory overload, that comes from probably just receiving too much product or receiving that product too fast, all right? Or it could be some type of underlying cardiac or renal issue going on with your patient. So some symptoms you will see will be dyspnea, orthognopenia, hypertension, and peripheral edema. Okay, so you will see these again. All right, so you can see if your patient is reacting negatively to that blood, they're having a reaction, stop the transfusion, right? Stop it. You want to perform those clerical, make sure your patient's okay first, right? Then you want to perform the clerical errors, make sure everything was ID'd properly and the blood type had the right donor, right? And then you want to draw a post-transfusion sample. Once you do that, send that to us. And then that first tier testing, we will run those tests. And then if it's suspicious, if we think there's some other things going on, we'll run additional tests. But for you, just worry about stopping transfusion, okay, if you're having a reaction. And then those clerical checks, some common errors that you see, misidentification of the patient sample. There may be a lab mix-up of samples, and then an incorrect recipient identification at transfusion, okay? Okay, so not so much for you all, but this is what we would see. So if somebody did have a transfusion reaction, when we spun down that lab and we look at that person's plasma, if we see that pinkish look in there, we see that hemolysis did occur. If it's visible, we will definitely annotate that and let you all know. All right, and then it goes over DAT again. All right, so the serological check, this is just our algorithm that we use in the lab. I said once you stop, this is just what we go through, not necessarily what you all need to know. Okay, so this slide is important, and the reason why this slide is important is because I'm going to give you a question, but I'm going to throw a whole bunch of labs at you, all right? So you're going to have a patient that went through, had a transfusion, they had a transfusion reaction, you stopped. And then you ordered all these tests, so I'm going to give you all these results. So it's going to be up to you all to siphon through those labs to determine what's important and determine what type of reaction your patient had, okay? So make sure you get this. So I may use a couple of these. I may put a chest X-ray result, a BNP result, and an IgA level, and you got to be able to determine, okay? So chest X-rays usually involve the lung. We're looking in tacos or in trolleys. We're assessing that respiratory distress. Your BNP levels are cardiac stress that differentiates a taco from a trolley. The ABGs, we may be determining that acid-base status or that oxygenation. This monitors that respiratory distress and detects a trolley complication. Donor testing. We'll do an anti-HLA and HNA. No, I will not put that on there because we didn't talk about that. So let's go down. Serum IgA levels, okay? IgA deficiency on a pre-transfusion sample. This could indicate some type of anaphylactic reaction. And then lastly, the serum anti-IgA detection. You also may see this in anaphylaxis if transfused with IgA containing blood. Here's some additional tests. I may add a gram stain result, and I may add a culture result, okay? And I think once you piece those all together, you'll have enough information to select the right answer for your test. All right, so this is just other potential transfusion reactions, anaphylactic reactions, and transfusion-associated graft versus host disease. And we have post-transfusion, or PTP, and then iron overload. So then here are the types of blood donations: allogenic, autologous, directed, therapeutic, and hemopheresis. All right, allogenic, that's your most common. That's what you see at the donor centers, the Red Cross, right? These are the ones that you will go in, you'll donate some blood that you're giving it to somebody else. That's allogenic. This is very highly regulated. There's so many tests that we do before we put that blood shelf or issue it to you as a clinician to place into your patient. Then you have autologous. So this is usually when a patient donates their own blood. This is before like a planned surgery. A lot of times if someone is, before they start any type of medication, sometimes they'll take this as well. But this does require a physician's order. Then you have directed. So this is blood that is donated specifically for a known recipient. So a family or friend. So you see this a lot in stem cell collections. You see this a lot with bone marrow collections. You'll have like this directed blood that also is used. Then you have therapeutic. So therapeutic, I will test you on that. Therapeutic is the removal of specific blood components to treat a condition. So that's for those PV, polycythemia vera. And so pretty much polycythemia vera, they have entirely too much blood. So we just need to reduce some of that and reduce excessive components. That's pretty much what that means. And then lastly, we have hemopheresis. That's a special donation. I know the donor center here on Fort Sam Houston does do hemopheresis. So if you just want to donate platelets or you just want to donate plasma, what they'll do is they'll hook you up to a machine. You'll kind of sit there for, I don't want to say 3 or 4 hours, and pretty much it's just going to be circulating through you. So you give the blood, it'll pull out the platelets, and then give the rest of your blood products back to you. So if your body can take it and withstand it, it's, it's honorable. All right, and it's very similar to dialysis, but the difference with dialysis is that dialysis, you're cleaning out the kidneys, right? You're cleaning out the waste and then putting the rest of that blood back into your body. All right, so this is just FYI. So you already know, if it's FYI, I'm not what? I'm going to test you. Yeah. All right, so that's ELO. So we talk about blood collection, blood components, alternatives, blah, 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 blah. Okay, and look, that's y'all. All right. So do y'all need a break? I have to do one more because, I skipped out yesterday. So if you need a break, let me know before you move on to the next one. Y'all need 10 minutes? Okay.
Which one are you doing, man?
I'm doing number 4. Yeah. Yeah, fluids. Okay. So let's do 10 minutes.
I know. Yesterday it was like, where's the heat at?
Stop. Why? Why are we not?
Yeah, it's too late. Don't get shot in the coat.
Yeah. Yeah,
You should get the one Oh, Lord.
I need her.
I like feet.
I'm playing like first experience. You get them out and no like. Sometimes worse. I appreciate it.
I was like, is it really worth it? Like, after all this work and they just Ryan sent me his thing and it's like, that's my meeting skills. Yeah, like I can check 3 or 4 hours right now. Being wasting somebody those out.
Where'd you get this from?
I just got an interview in a hospital tomorrow. So just looking it up, seeing what they're about. I don't know, yeah. Just started reading about it. Part of like that.
Where's it at?
No, it's in Sarasota.
For the first part, so I'll be here for 10 weeks.
It's like neuro supposed to be good. Seem like maybe it's just the head of the two different. It's not like it seems like a weird combo you didn't have. But it's like for like a stroke specialty care residency program or something. Yeah, I think she wanted
Like that's no reference to that wall.
Most of the kids are fine. It's a giant thing of just motors.
There was one time I there's two of them. One that was like a big.
Griffin's trying to go to
I would call
Ohio.
that like a.
Trying to go to Ohio.
so like
Trying to go to Ohio?
yeah, all my family, all my mom's side of the family lives in Dayton. So it'd be a nice
I'm like, I'm just gonna change everybody's stuff when it comes time to like final submission.
just like start switching it around.
Sunday night, I'm just changing everybody's.
On the side of the
You're going. Nobody like. There's like 2 people want to go.
I mean,
And you're one of them.
Right? Where I was like, that's quite a few. And I was like, thinking in my head, I was like,
I've always wanted to go to Germany. And I feel like this is like, are you ready for the year? I don't want to go for 4 years. I'd rather do 4 years. You're gonna be busy doing rotation.
That's like, wasn't fun.
4 years, you can actually plan your travel to where you want to go.
I might have to transfer again for some special.
I don't know about anymore.
I mean, the thing is, like,
How long is the flight?
60 hours. It ain't short.
I mean, it's only in Pennsylvania, so it takes 2 or 3 hours off.
It's expensive though. I don't know. We'll play by ear. That would be a good route. At least one of those 2. But FIBA or like super smart.
I'm fine.
Oh. Randy sent me a friend request.
All right, y'all. 10 minutes is up. Let's not fluids out. So fluids is gonna be pretty easy because we talked a lot about fluids in block 2. So we're gonna do more emphasis on like lumbar puncture, CSF. Okay, that's what y'all really need to know here. So here are TLOs and ELOs. So we're gonna talk about serous fluid differentiated between transidates and exudates. We're gonna talk a little bit about synovial fluids. We're not calling semen. And we're gonna talk a little bit about amniotic fluid today. All right, this comes from chapter 30 in your reference. And here is our clinical introduction scenario. All right, a 35-year-old male presents to the emergency department with fever from effusion, and a stiff neck. A stat lumbar puncture reveals cloudy CSF with elevated white blood cell counts, low glucose, and a positive gram stain for gram-negative diphyllopoxide. Concurrently, a patient in the OB triage with suspected membrane rupture undergoes a FERN test, and this confirms amniotic fluid leakage. Both cases require timely fluid analysis to guide life-saving treatment and OB decisions. Okay. So, body fluids. Serous fluids, you got pleural, pericardial, and peritoneal, synovial, amniotic, and CSF. Right, so here are your fluid types, and I know y'all know fluids, right? But some of the serous fluids, some of the things that we test in the lab, all serous fluids would be red blood cell, white blood cell. We'll look at the morphology. We'll look at protein. We'll look at lactate dehydrogenase, glucose, and we may send stuff to microbiology. For synovial fluid, we're looking at color, clarity, and viscosity. We will also run the same thing, but we will do an additional examination for crystals. And y'all remember those two crystals we talked about before for gout? Where are they?
Mono.
Y'all don't see that here. All right, and then CSF fluid. We look for color and clarity. We also look for the same thing: red blood cells, white blood cells. We can run chemistry, serology, and microbiology on CSF. And then amniotic fluid, we run AFP, bilirubin, creatinine, and chromosomal testing. We also look at that LS ratio. We don't do that too often, but it does happen if there's something going on with the lungs of the babies. So you all know this stuff because y'all went through AFP, right? Y'all know pleural, pericardial, where it's located.
Heart, lungs.
Okay. So serous fluid is collected by needle aspiration. So specifically, it's fine needle aspiration. Now you won't have fine needle aspiration in your roll ones, but in the hospitals you will. So an FNA will be coming from a lab tech, specifically a cytotech. So if you have a patient and you have some fluid that maybe you want to take off the lungs, you can have a tech right next to you to your bedside. They'll have a cart with a microscope there. You can give them that fluid that you collected. What we'll do is we'll take a drop of that, put it on a slide, and we'll stain it really, really quick. We'll look at it under the microscope to determine if you're in the right area or determine if there's cells in there that you're looking for. Now, we can't give you a diagnosis at the bedside, but we can let you know that yes or no, there is something in there that needs to be evaluated, okay? So we have thoracentesis, which is the aspiration of pleural fluid cavity, cardiocentesis, the pericardial activity, and then the paracentesis, aspirations from the peritoneal cavity. All right, so pleural fluid, reasons for analysis, pleural effusions, which is excessive fluid in the pleural activity, or there could be lung cancer if there's pleural fluid. Okay, so common cause could be heart failure, infections, or cancer. And some associated symptoms: shortness of breath, chest pain, cough, fever, chills, and fatigue. Okay. Pericardial, you will see pericardial again. Specifically, you will see pericarditis. So pericardial inflammation, which is pericarditis, or cardiac tamponade, which is fluid compressing the heart. Okay. So I want to give you a scenario of somebody that has pericarditis. Okay. And then peritoneal, which is that ascites is fluid in the peritoneal cavity, or peritonitis is inflammation or infection of the peritoneum. All right. All right. So, serious effusions, transudate versus exudate. These are two types of effusions. So, transudate is caused by systemic disorders, so chronic heart failure, nephrotic syndrome, or blocked vessels. And transudate, this is a disrupt fluid filtration and reabsorption through hydrostatic and oncotic pressure. So any type of transudates in the lab, when we test it, it'll have low protein and low cell count. All right, for exudates, this is caused by inflammation. So anytime, what are the cells that we associate with inflammation? Remember, white blood cells, okay? So it'll have high protein and then high cell count. Right, so that's the difference between the two. Transudate is going to have low protein, low cell count. Exudate is going to have that high protein, high cell count. All right, and so this is just another slide of what that looks like. If you like pictures, this is what it looks like. Okay, you'll see this again on your test. And here it is again if you like to see it in the chart form. Okay, so transudates non-inflammatory versus exudates are inflammatory. Okay, and specifically in an exudate in that high protein, that's in hyperproteinemia. Transudates low protein, hypoproteinemia. All right, so this is what it looks like in the lab. When you give us those samples, we'll put it in these tubes here, and we will always look at the appearance first. So a normal appearance will be clear, straw-colored, and has a low viscosity. Abnormal would be that it's turbid, viscous, or colored. So in turbid, you have it's considered high white blood cell count. So turbid is anything that's greater than 200 cells per microliter, and anything that's purulent is greater than 10,000 cells per microliter. All right. Viscous means that it's clotting or hydrolyzed debris is present, and then if the color is red or pink, means that there's a presence of blood. So if it wasn't a traumatic collection, if it was a normal collection, there's still blood in there, that probably means there's some type of malignancy going on with your patient. And so this is just what it looks like under the microscope. You all won't necessarily see that, but we will. So we'll take those we'll take those fluids, we'll spin them down, we'll take the pour off the supernatant, we'll pull the cells off, place it on a slide, we'll stain them, and we'll run all kinds of additional testing. So we'll have cytological examinations where we're looking at different white blood cells, we're assessing for cancer and inflammation, and then we can also send those fluids to the microbiology section where we perform gram stains, do cultures, or AFP smears. All right, and so this is just a summary again. All right, if you like the way this looks, you can study this slide. All right, so synovial fluid. Synovial fluid is from your joints, so knees, elbows, fingers. Okay, it contains that hyaluronic acid and used to reduce friction during joint movement. So these are some of the functions. I think y'all learned all of this in A&P, so I will not get that again over for you all. What you all need to know is how we distinguish the different arthritis types. So we differentiate an infectious versus a non-infectious arthritis. And then we classify synovial fluid group by reactive types based on the clinical context. Okay, so this is how we look at synovial fluid in the lab. We have 3 classes, and then we have hemorrhagic and crystal induced. All right, so class 1 is non-inflammatory. This is seen in osteoarthritis or degenerative osteoarthritis. So that class 1 is that second tube there to my right, your left. That's class 1. Class 2 is inflammatory. This is associated with immunologic disease like lupus or rheumatoid arthritis. Then we have class 3, which is infectious. So this indicates some type of bacterial infection. Then we have hemorrhagic. So you'll see this a lot in patients that have hemophilia. And then lastly, we have crystal-induced, which is that gout or pseudo-gout. And so you will see crystal-induced gout or pseudo-gout. You will see that again, okay? All right, and this is just what it looks like. Same stuff, different slide. And then for synovial fluid, if we have to send it to micro, again, like I said, we'll run a gram stain. And then for there, we're looking for bacterial arthritis, which can rapidly damage joints. We can also run chemistry tests on synovial fluid. What we're looking, we will run glucose and protein chemistry. And then in immunology, we'll run what's called an anti-nuclear antibody test. And so this test will detect those auto-antibodies if that's what's going on with your patient. So those will be used in any autoimmune disease like rheumatoid arthritis or lupus, okay? So again, like I had stated before, I'm going to give you a series of tests, okay? So you're going to have a patient, you collected synovial fluid. This is the result of a micro. This is the result of chemistry. What does your patient have, okay? So just get into that mindset. That's what you're going to see. All right, so here it is again, characteristics of synovial fluid. those different classes. Class 1 is non-inflammatory, class 2 is inflammatory, class 3 is infectious, and hemorrhagic. Okay? And so you will see these, I'll do my best to keep it on as clean as possible and have high resolution images so we don't have any issues like we did in the last test, okay? But make sure you're starting this because you will see, I will present this to you, okay? All right, here we go. Here's that gout and pseudo-gout. So I know y'all know this already, but for whatever reason, I got to test y'all again on it. So start that slide. So just remember that the crystal for gout is MSU, negative bariverts, whatever, I can't say that right. And then pseudo-gout, that CPPD is positive, okay? All right, so let's move on to amniotic fluid. We are almost done, y'all. All right, amniotic fluid, this protects the fetus, all right? This protects that baby while that baby is in the womb, all right? If amniocentesis is usually done if there's a suspected genetic disorder, the lungs are not maturing adequately, or there's some type of infection, amniocentesis will be performed between 15 to 20 weeks of pregnancy. Okay. So here it says advanced maternal age, but according to the OB, they think 35 is advanced age, and I'm just a little offended by that because I don't think that's old. But anyway, just because you're 35 and you have a baby don't mean you have to have amniocentesis. It's usually for those that have a history of genetic disorders, right? Or, like I said, fetal lung maturity. If the lungs are not maturing correctly, or there's some fetal abnormalities, okay? Okay, so amniotic fluid examination. In the lab, we're looking for chromosomal defects. So we're looking at, we'll do a chromosome analysis, or that karyotype is performed to ID the gender, or we'll look for genetic abnormalities as well, like Down syndrome or Edwards syndrome, okay? We will also look for neural tube defects, or NTD. That's that alpha fetal protein. This is produced by the liver of the fetus and plays a vital role in the development of the fetus. So an elevated AFP may indicate some type of neural tube defect, such as spinal bifida or encephalopathy. And then lastly, the quad screen, which is a common test. Usually in normal pregnancies, a quad screen is just taken from the blood, but we can also do a quad screen on amniotic fluid as well. And so those will measure those NTDs or chromosomal conditions. So just make sure you know the test associated with neural tube defect, which is that AFP, and know that the quad screen does test for those chromosomal conditions. Okay, so here it is again, what I just said. All right, so if you need to see it differently, here it is. So amniotic fluid, if it's low AFP, trisomy 21, that may be Down syndrome. Low AFP, trisomy 18, Edwards syndrome. And then the quad screen, we're looking at if it's chromosomal defects, low AFP, the pregnancy, the HCG, and estradiol, and high inhibition A. So, like I said, just know alpha fetal protein, no AFP, okay? Because I will ask you about AFP. Right, so hemolytic disease of the newborn. If there's a baby that had fetal RBC hemolysis, usually the amniotic fluid will have high bilirubin levels, and will detect abnormal hemolysis to manage or prevent complications. A test that's not very common, I don't know why it's up here, but it's not very common, but this LS ratio, this is a measurement of fetal alveolar surfactant that tests the lung maturity. It's not very common, I'm not going to test you on it, but it's good to know. Okay? All right, now CSF. We know CSF touches the brain, the spinal cord, and it delivers nutrients and excretes waste out of the lymphatic system. Okay, this is how it looks anatomically. Okay, so CSF. The purpose of a CSF, we will do CSF analysis if you do lumbar punctures and you send it to us. Do y'all remember from the previous lectures how many tubes you're supposed to send to the lab with CSFs? Do y'all remember? And do you remember how many, did we talk about how many drops you put in each? Oh, yes. All right, good. All right, so when to test. All right, so if you have infection symptoms, fever, headache, confusion, this might mean meningitis or encephalitis, head trauma, you want to rule out bleeding. You may have some neurological symptoms, unexplained seizures, altered mental state or defects. MS, you want to detect specific proteins, and monitoring of CNS disorders. Okay. And these are some common CNS symptoms. So I will use this. You will have a patient that will come into the ED. They may have some of these symptoms, and you're going to need to do a lumbar puncture on them, okay? So I use this somehow to come up with a question. All right? Meningitis and encephalitis. Meningitis is inflammation of the meninges. The symptoms include fever, headache, nausea, vomiting, photophobia, and stiff neck. Okay, encephalitis, seizures, confusion, altered consciousness, and focal deficits. All right? Yes, I think I did come up with a question for meningitis as well. And here it is broken down. Bacterial meningitis comes from Neisseria streptococcus pneumoniae. Yeah, you said it right. And Haemophilus influenza. Viral, enteroviruses and herpesviruses. Fungal meningitis, cryptococcus cystoplasmosis. Parasitic, Gilia fowleri, I know I'm saying that wrong. And then mycobacterium tuberculosis or other mycobacteria. I'm not going to break it down. I'm just going to ask you if this person has meningitis or not. Okay. And then meningitis, here it is broken down by the different age groups. And I had already tested y'all in the group B streptococcus, so you will not see that again. All right. So encephalitis, viral encephalitis is the most common cause of encephalitis. And so since it's most common, then I'm probably going to test you. Okay. Common causes, herpes, West Nile virus, Japanese encephalitis, and others. Treatment will be supportive care and antiviral medications. All right. Then you have bacterial, parasitic, and fungal, but viral encephalitis is most common, which you will see again. All right. And here's a brain hemorrhage. All right. So the tests that are associated with brain hemorrhages are CSF exam. So we're looking for red blood cells in the CSF, and then a CT will also be used as well. Your patient has intracerebral hemorrhages. Some laboratory tests will be the CBC and blood pressure monitoring, and then lastly, the cerebral infarct key test would be the lipid profile and coagulation studies for brain hemorrhages. Neurological diseases. All right, MS. All right, MRIs would be the best way to detect that. We don't have a whole bunch of tests in the lab for that. Yeah, and it doesn't look like it's a lot of labs, so skip. All right, so collection of CSF. I don't know if y'all will do that here in phase 1. Maybe in phase 2 you may get to. So here's a lumbar puncture, the spinal tap. You insert that needle into the spinal canal to extract that CSF. Y'all already remember it was 4, and y'all know it's 10 drops per. So y'all good in my book as far as lab is concerned in CSF. Okay? Yep, y'all are good here. All right, so that first 2, we'll go to chemistry. We'll run those chemical and serological tests, so glucose, protein, and other chemical tests. Tube 2, that has to remain at room temperature. Tube 1 also needs to be frozen. So tube 2, we'll go to micro. We'll run gram stains, cultures, and PCRs. Tube 3 will be refrigerated. That's where we will get our total and differential cell counts. And then lastly, tube 4 will exclude skin contamination or additional tests. A lot of times that 4th one we kind of share if we need additional samples to run additional tests. Okay, that's the best practices. All right, and this is just showing the appearance. This will also show up on your lab reports. We will let you know if it's turbid, so that if it's turbid, that indicates cases like white blood cells, bacteria in there, or baby proteins or lipids. If it's clots, this could be from a traumatic tap, or it could be very high levels of proteins. And then the color, I know we had talked about this in number block 2, about the successive tube should show less color in a traumatic tap. I know it's a money slide, but it's not a money slide, okay? That's not a money slide. So. All right, so CSF, serological tests used when PCR is negative to detect specific pathogens. And then neurosyphilis, this is diagnosed at the BBRL, which is on, what's BBRL? I think it's in Maryland. Yeah, the Venereal Disease Research Lab, we do use that a lot. We have esoteric testing that we're unable to do at our labs, we will send them to research labs. And so they test other additional pathogens, cellular and micro. So measles, rubella, West Nile, toxoplasmosis, HSV, and varicella zoster. Yellow.